Hi everyone. Lovely to see everybody here, and thank you so much for joining us today for NHS Highland's annual review for 2024-25. Just before we get started, so you are aware, I believe that we have STV with us who are filming. Just to pause for a moment and check that everybody's okay with that. Speak now or forever hold your peace. Okay, great. I'm Sarah Compton-Bishop. I'm chair of the board of NHS Highland, and on behalf of the whole board, I'm pleased to present to you our progress and our challenges for 2024-25, and take the opportunity to talk about the vision for the year ahead. So this year has been a year of transformation, but delivered against a backdrop of considerable financial and operational pressure. I'm just going to play a really quick video before I move on. So those were some of our staff in just some of our communities that we wanted to share with you. So the theme for this year is strategy, sustainability and service excellence. And these are the principles that have guided us from how we're tackling our financial challenges and how we're redesigning services to meet the needs of our communities across the Highlands and Argyll and Bute. So I'll start by outlining the unique challenges that we face. Our population is older than the Scottish average, with increasingly complex health needs spread across 42% of Scotland's landmass. We span the East Coast, the West Coast, the North Coast, and all the way down the Kintyre Peninsula. Our geography and the spread of our geography brings challenges around transport, housing, childcare, and rural deprivation that affect both our patients and our staff. We have high numbers of delayed discharge. So when we have people waiting in hospital when they could be better cared for at home with the right support or in a different care setting. We face care at home and care home capacity challenges and recruitment difficulties, particularly in our specialist areas. We face a range of workforce challenges, including seasonal tourism, which impact our ability to maintain consistent staffing levels. Whilst these challenges are complex and persistent, we're clear and focused on finding sustainable solutions that are going to work for us here in the Highlands and in Argyll and Bute, and we'll touch on some examples as we move through the presentation. The financial context has been stark. We opened 2024-25 with a forecast deficit of 112 million. Through determined efficiency work, we reduced that by 62 million. And that left us with a final position of 49.5 million. That was met with some brokerage from Scottish Government of 49.7 million, which left us with a small surplus. So if we look then into 2025-26, we face an even more significant financial challenge. We're starting with a funding gap of 110 million and a projected 55.7 million deficit. And while we've been told clearly by Scottish Government there will be no future brokerage, they have committed to 40 million in deficit support funding, which leaves us with a 70 million debt savings target to close. We'll deliver that through a range of actions. We plan to deliver 34.4 million in cost efficiencies, 15.6 million in non-recurrent actions, and 20 million in social adult care improvements. This fiscal position, and indeed the broader public sector financial position across Scotland, make it very clear that we can't continue in the same way. strategic transformation is essential. And while there's a clear need locally and nationally to transform to address the financial pressure, there are other drivers for that change. And indeed, we're seeing positive results. The work that we've done has driven innovation, service redesign, and creative workforce solutions that are improving care, and some of those will come through in the presentation. So our Together We Care strategy translated into 7 major transformation programmes. We're implementing person-centred pathways, integrated urgent care, and focusing on prevention and health inequalities. We're developing integrated care models, strengthening our primary care strategy, and transforming services in mental health, learning disabilities, and frailty services. These programmes are delivering sustainable, more equitable care across our entire region, but there's still work to be done. We know that transformation works best when we do it with our communities and with our partners. Our integration model with the Highland Council is continuing to evolve, very live discussions at the moment around that, and our collaboration with Argyll and Bute Council and the integration board in Argyll and Bute is strengthening. We've delivered some innovative partnership solutions, like the joint ownership approach we took for the Moss Park Care Home. And through locality planning, we have community voices actively shaping service design through district planning groups and community planning partnerships. Community voices are helping us shape our future services. The Loch Harbour service design is a really good example of that, with local groups coming together with our teams to design those solutions for future health and social care in the area. Prevention and reducing health inequalities are being embedded across our services. In line with the Scottish Government's population health framework, our future strategy will have these principles at its core, taking into account geographic health variations, fuel poverty, cost of living impacts, and access barriers in our remote communities. So what does that mean in practice, in real life? We treat and support everyone who needs us, while we also work to prevent people from needing us through vaccinations, screening programmes, early intervention and early detection, and working with our partners on the wider determinants of health. We can't just look at treating illness, we need to work together to increase wellness. It means being a good employer, because fair incomes and safe workplaces directly support health. It means looking beyond our own services to consider the impact that external factors have on health and well-being. Things like housing, employment, socioeconomic factors, lifestyle, activity, environment, community. It means we need to work better with our partners to improve these things. This population health approach underpins our transformation work. We need to work with communities to design solutions that address the root causes of poor health and not just treat the symptoms. It's helpful to see some real-world examples. I've picked just 2, but there are more. In Highland, we piloted something really innovative. It was in February this year, a musculoskeletal community appointment day in Inverness. It was organised jointly between NHS Highland and High Life Highland. We had, I think, about 370 patients who were waiting for physiotherapy appointments to come to this 2-day event at the Inverness Leisure Centre. And we worked with partners in lots of different sectors to bring together 15 different NHS teams and lots of different third sector partners into one location. So we created a one-stop shop. And we saw some fantastic results. We cut waiting times quite significantly, down from 60 weeks to 8 weeks. Patients rated the experience as really positive. So I think out of a 5-star average, it was 4.75. And we also saw 43% of attendees signing up for High Life Highland fitness classes or leisure services on the spot. So we were seeing prevention and self-management happening in real time, in partnership. It worked really well, and we're going to be doing more of this. And another example from Argyll and Bute, our hospital at home service in Inverness is delivering hospital level care in people's own homes. So this grassroots service has been built on really strong community collaboration, and it's achieving exceptional patient satisfaction with its person-centred approach, and it is delivering proven impact on reducing those hospital admissions. So both examples show transformation that starts with understanding the community need and building outward using our partnerships. We want to create sustainable person-centred care in practice. For some of our specialist services, achieving the best care means changing how we deliver them. So the reality is that some of our services, like vascular surgery, require a critical mass to maintain quality and safety. Oncology expertise needs to be concentrated for better outcomes, and single site models can make recruitment incredibly difficult. These are contemporary challenges that some of our specialisms face. The Scottish Government Service Renewal Framework, you can see a picture of it there, recognises that we need both specialist clinical care and local accessibility. In line with this framework, our approach is to develop pathways with partner boards, creating centres of excellence for complex specialist care, while working to enhance what we can provide locally by way of assessment and support and keep that closer to home. This can be supported by better use of technology and joined up care across organisational boundaries, but we recognise that there's more to that. We heard this morning or earlier in our patient group that technology isn't the only answer and isn't always the right answer, so we need to work around that. And for our workforce, this means opportunities to deliver care through new networks, collaborative working, and operating in different networks. Going forward, people across Scotland will be accessing some services in new ways. And whilst we know that change can be incredibly challenging, our commitment is to deliver evidence-based service design, which balances safe specialist expertise with local services and support. So I'm going to talk a little bit about performance now. I want to highlight a success story to start with around our psychological therapies. So we had a focused improvement plan, which was managed by the service, and we recruited 2 new clinical psychologists in adult mental health psychology, established a psychological therapy steering group aligned with the national specification, and introduced increased data scrutiny with a new digital dashboard, so helping us with our reporting to Scottish Government, but also helping us to understand what was working. And that data-driven approach has allowed us to use that intelligence proactively to improve the waiting times in that service. The results are really positive. In March 2025, we achieved 87.4% of patients seen within 18 weeks, which is better than the Scottish average of 79.7%. Still work to be done though, and we saw that improve further. So by June 2025, we hit the 90% target, making us the top performing mainland board in Scotland. We are seeing strong performance across a number of areas despite our rural challenges and increasing complexity, and we need to build on that. So we know we've got areas for improvement. We've got significant work to do in scheduled care, reducing waiting times beyond 52 weeks for new outpatient and treatment appointments. Cancer waiting times, so both the 31 and the 62-day targets, require improvement which we can sustain. In unscheduled care, we need to reduce our delayed discharge, improve the flow, and therefore improve A&E performance towards that 95% 4-hour standard and reduce the length of stay. And they're just some of the metrics that we're monitoring really closely, by the board of monitoring that in line with the Scottish Government's operational improvement plan. And that's focused on critical areas for delivery to help protect the quality and safety of care. And that's supported by increased investment for health and social care. I'm just going to focus for a moment on scheduled care targets. So we're working to see 95% of our patients within the 12 weeks. We must reduce new outpatient waits over 52 weeks, and we need to do that by March 2026. So we're looking to go from 5,000 as it was in April 2025 down to 1,393, very specific, by March 2026. Treatment waits over 52 weeks must drop from over 900 to just 200. For cancer, we're targeting 95% beginning treatment within 31 days of decision to treat and improving our 62-day urgent suspicion of cancer pathway to 80% by March. And for CAMS, we're committed to achieving the 90% within 18-week standard by December. In unscheduled care, our target is 83% of patients seen within 4 hours in A&E by March 2026, while striving towards the 95% national target. We're working to minimise those longest waits. Delayed discharge must reduce to fewer than 188 by March 2026. We're doing really well in maintaining our ambulance turnaround times above the national average, and we're introducing 15 hospital at home virtual beds in Highland and expanding to 60 in Argyll and Bute in March. These are all really stretching targets, but they are achievable. So how do we do it? So for scheduled care, we're making additional investment to target the longest waiting patients, and we're currently ahead of schedule in reducing those over 52-week waits. For unscheduled care, we're shifting the balance from acute to community settings. There's a lot that we can do outside of physical hospitals now, and that's a real positive when you think about our geography and the spread of our communities. We're expanding hospital at home. We're growing same-day emergency care at Regmore. We're implementing advanced practitioners at the front door and aligning our flow navigation centre with out-of-hours services. Consistent discharge pathways and embedded rehabilitation services are key to success. We're designing new ways to treat people safely while reducing the need for hospital stays. So that's good for us, it's good for the system, but it's also good for our patients as well. For cancer, we've implemented weekly escalation and monitoring of every patient with targeted pathway improvements expected to show results by March. And in CAMS, we've made significant strides through our improvement plan overseen by the programme board. Since April 2024, we've introduced effectiveness of engagement appointments for earlier assessment and risk screening, maintaining a rigorous focus on the data, integrity, and actively recruited while reviewing the skills mix to make sure we're making the best use of the teams that we have. The results are encouraging. We reduced our waiting list from 245 in April 2025 to 123 in October. So we're currently at 89% and we're on target to achieve 90% standard for patients starting treatment within 18 weeks by the end of December. So talked a lot about finance and numbers and services, but none of this happens without our people. Our staff are and always will be our greatest asset. They are what make the NHS. This year we've been delivering leadership and culture training. We've had well over 100 colleagues have completed that so far, and that's ongoing. So we'll keep rolling that out to support the teams. And as I looked back over some of Fiona's chief executive reports over the year, I was overwhelmed by how many of our staff from all over the Highlands and Argyll and Bute have won a range of awards. Too many to mention, but a real testimony to the excellence and the dedication we see from all of our teams and all of our communities every day. We've delivered phase 2 of our culture and leadership framework. We've achieved major reductions in high-cost agency usage and rebuilt our e-rostering system at Regmore to comply with the Health and Care Staffing Act. We've completed our workforce monitoring report, we've progressed our EDI workforce strategy, and we've established a learning and development group. We're building systems and frameworks, but what's more important is we're working to nurture a culture of professional development, excellence, civility and safety. And what about the board? So we know that strong governance underpins our business and our quality. So I'm pleased to report that all the actions from our Blueprint for Good Governance plan are either completed or well progressing. We've completed a number of committee self-evaluations. We've implemented an annual work plan framework. So that's an improvement on how we manage our business through our committees and our board. We've recently created a new committee of the board to drive forward that population health topic that I touched on earlier and our transformation work. Our independent auditors were assured by the effective and efficient achievement of objectives, and that's accountants speak for you're doing well. When they looked at the previous year, that had been an improvement. So good governance is part of the foundation that supports frontline excellence. It's a check and a balance. It helps us scrutinise past performance and set the direction of the future. And it's something that's constantly being reviewed and improved on to respond to the changing needs. We're evolving how we measure performance to ensure that we get the right data to assess quality, safety and efficiency, while also understanding outcomes and patient experience. As we look to the year ahead, we're updating our strategy to build on the strong foundations we've already established. Our region's demographics are shifting, our population health requirements are changing, and we need a strategy that reflects that reality and responds to the world that we're now working in. We're aligning ourselves with the Scottish Government's Population Health Framework and the Health and Social Care Renewal Framework, embracing those principles of prevention, people, community, population and digital. These policy documents are the frameworks we will take forward in our local context to ensure progress, sustainable change, and most importantly, good outcomes and services that work for our population. With this strategic direction in mind, I'm going to finish up with some commitments. So firstly, sustainable services. We'll keep progressing our transformation programmes to ensure the long-term viability of care across our communities. What we do to fix things that aren't working have to be things that we can sustain for future generations. Secondly, partnership delivery. We're working to deepen our integration with the councils and our work with communities to achieve better outcomes together. We know that this is about joined up care, prevention before crisis, support in communities and person-led services. And we can't do that on our own, and we can't do it if we work in silos. So we have to recognise and work with the strength and expertise that our communities and local partners have and really embrace that. Third, workforce excellence. So we'll continue to work to support and grow our teams to meet both current and future needs. We want to empower our staff to work in new and collaborative ways. Again, our people are our greatest asset. So we're building on progress, but we are being open about our challenges. Despite that, we remain absolutely focused on improving outcomes for the people of Highlands and Argyll and Bute, and to work on what matters most to the people that we serve. Thank you for listening. This is, of course, a chance to open up. We have got a number of questions that have been submitted in advance, but also it's a great opportunity to take questions from the floor as well. So if anybody wants to ask a question, stick your hand up and we'll find somebody to respond. And what we'll do with other questions, if anybody's kind of watching this back or wondering, all questions that have been submitted for the annual review, if we don't get time to answer them in this session, all of them get published on the website along with the answers. So even if we don't get to your particular question in here, the responses will be up on the website. So does anybody in the audience want to go for a question, or will I warm us up with a prepaid one? Yes.
Interesting how you mentioned a financial situation within NHS Highland, but you failed to mention the financial impact locums are costing the organisation, which is, you don't need to be current parliament to work it out, it's costing an absolute fortune. So what work is being done to reduce the amount spent on locums by recruitment and retention? Because whilst you're going about finances, patients don't really care about that. They're more care about continuity, which is killed with locums.
Yeah, great question. So there's a number of people I think could answer that. So who should we take? Well, we can talk about recruitment and we can talk about what we're doing in the service. So Gareth, I'm going to put you on the spot and talk about recruitment first, and then I can come to other execs to pick up the other bit of that question.
What's your position?
Sorry, Director of People and Culture, Gareth Atkins.
So he'll do the recruitment bit and then we'll...
So I suppose there's different elements involved in looking at our workforce supply in general. And one aspect for that is looking at what the right skill mix is for the services. So one option we do have to look at, we have been looking at different places, is the types of roles that we recruit to. So in areas where we do have dependencies on locums, we are looking at alternative models. So we might be using advanced nurse practitioners, for example, to take off some of that workload that could be done by somebody else other than a medical locum. We've got tight control. So in terms of thinking about workforce planning, that's one of the elements. We know at a national level there is a supply and demand issue around the availability of medical workforce across Scotland. It's not just Highland that experiences that. So working with National Education Scotland as well, looking at that pipeline for the future, increasing the number of places that are available at university for medical students, etc. So there's a lot of things that are multi-layered in terms of workforce planning to try and address that gap going forwards. We also have we put in place controls in looking at when we utilise locums, so we've exhausted all other possibilities. Obviously, the thing we need to take into account is the balancing of that against delivering safe services and having people available to actually deliver the service. It's not our preference. We do want to move away from losing locums and have substantive staff in place, but it is a challenge that we face in terms of bringing people to the Highlands and attracting them to some of these areas. So it's quite complex and multifaceted, but we are focusing on trying to reduce that. In terms of recruitment, we've also looked at international recruitment and routes bringing people from overseas, but that's been particularly successful around our nursing workforce. And we're also been considering that from the perspective of medics as well. Another route we've been looking at is something that's called a portfolio approach to bringing people up to consultant level. So that's bringing people through an alternative route to demonstrate the competency to become consultant. So there's lots of initiatives we're pursuing to try and reduce our dependence on locums.
I think you made a really good point though about patient care and patient experience in that. And I wonder, I don't know if one of the other executives could come in about where we do have to use locums. As Gareth said, maybe we've exhausted all the other options and we have to use a locum. How do we ensure that quality and that continuity of care for our patients? And I don't know if I could ask one of the other execs to come in on that. Fiona, go and pick someone. You're looking at Boyd. I'm going to ask you to come up, please.
Hello, Boyd.
Peter. Yeah, thanks. Boyd Peters, Medical Director. So locums, where we have locums that we need to use, the preference is to get locums who are going to be here for a while, so that they can integrate with the team and learn the service more fully, get to know the people and the patients and people that they serve. Very often we are able to do that and retain locums for a reasonable length of time. There are people who are at a stage or place in their career where they don't want to take a permanent job anywhere, but we're delighted if they'll come and work with us as opposed to anywhere else. And as already described, there are recruitment challenges nationally, and we're at the back of the queue because of our geography quite often. But we do, when we have locums, try to make them very much part of the team as if they are permanent staff as far as possible, and allow them to build that relationship with their colleagues and with the people, patients that they serve.
Thanks, Boyd. Okay, any other questions from the floor? Yes.
Hi, so mental health, learning disabilities, and for the families of the patients that are there, quite often it's like it's the second class or poor relation to the mainstream. You mentioned that you're going to improve mental health and learning disability services. Can you tell us how you're actually going to do that?
I can't, but I can hand over to someone who can. Who would like to come up so that everyone can hear?
Yeah, thank you. I'm Arlene Johnson, Chief Officer for the Highland Health and Social Care Partnership. So we've developed in collaboration and with our communities a mental health and learning disability strategy, which is now set out and has a delivery plan, which includes a variety of different measures, some of which probably picked up in other elements of the meetings today, is around about improving communication with people, improving access to services, including the information that we have available both digitally and in a variety of different formats. We're aware that those is not, and it's not as accessible as it should be at the moment. In relation to how do we improve kind of some of the more, I suppose I'm thinking about some of the conversations we've had earlier, which maybe is slightly different, about how do we improve services for people with a learning disability, particularly those individuals who are perhaps looking for housing and support at once. And we have got a new work stream as part of, since I've come into post in the last 3 months, we've kind of looked at the governance, and we've been looking at the work streams that we've got. So we have a new work stream which will look specifically at young people coming through transition and what their support needs will be, so that we can do much more earlier planning around about making sure that we work with our colleagues in the council to ensure that we've got the housing that people require, and that we work with our partners in the independent sector to work out how do we recruit differently than we are at the moment. We know that it's not necessarily working and that we're struggling to find staff that are willing and keen and able to work with individuals. And so how do we work in partnership to move that forward?
A work in progress.
Indeed, exactly.
Okay, thank you. Okay, any other questions in the room? Oh, yes.
We've been working with a lot of different health boards this year, getting kind of tools approved for use in regions to help on some similar cases, such as yourself, things like paralysis templates, recalls in primary care. While some are able to get assured and have progress in practices, it's been a bit of a challenge in the Highlands. I don't know if you could shed any light on why there may be kind of blockers to things like assurance, there are other priorities.
Sorry, can you just explain?
In terms of getting tools kind of approved for use, primary care, like the digital tools that practices can use to help kind of communicate with patients. It's been a bit of a challenge getting anything assured in the Highlands. I wasn't sure if there was any delays in getting things assured, or if shed any guidance on how best to kind of improve that.
Okay, sorry, can I just check, where are you from? You sound like you're from an
Correct.
Okay, not something I'm familiar with, but thank you for the question. I don't know who wants to take that question. Oh, David's leaping up.
Yeah, thanks for the question. I'm David Parker, Deputy Chief Executive and Executive Lead for our eHealth team. I think the development of both technology, AI in particular, is a very hot topic at the moment. And so we are working both locally as well as nationally with our NHS Scotland colleagues to make sure that we are able to advise and adapt technology for use within the healthcare environment, making sure that data is protected and that we're using it in a safe way. That sometimes can mean that we're a bit slower in adopting some of that technology than we might maybe in other types of industries, but you'll understand our cautious nature. We have a very regulated process for impact assessments and so on, but we're also keen to make sure that we don't lose the opportunity for innovation. So it's a very fine line that we're trying to tread to encourage innovation, but do it in a very controlled way. But if there are specifics, I'd be more than happy to talk to you about it after the event. So thank you.
Okay. Any other questions from the floor? Oh, yes.
I'm Monica Lim, person representing Chinese community and ethnic minority. I just want to find out what is your protocol regarding early send back from hospital stay. Someone has a fall in the hospital, you want to free up the bed. What is the protocol? Do you always have a care plan before you send the patient home? Because recently I have an elderly has a fall, and because as always, our age group always try to be independent, don't want to be a fuss. So he said, I can manage, but actually she can't. Her bathroom is upstairs, and then living room, bedroom is downstairs. So how do you have a care plan always before you send a patient home.
Okay, Arlene, that might be one for you or I'm looking at lots of people here.
Yep.
The team effort.
Good indeed.
Hiya, I'm Louise Bassell. I'm the Nurse Director for NHS Highland, and the answer should be absolutely yes. We should have a plan for everybody being discharged from hospital in terms of what that might mean for them. Some people may be completely independent, but we still need to check out with them that they're okay to go home, that they've got food in or whatever that might be. But equally, there will be people with more dependency needs that we need to have that plan in place with. I fully acknowledge there may be occasions when that isn't always right and it isn't always how it should be, and those are the ones we need to hear about and we need to learn about and make sure that we do that properly. We have new innovations coming online as well in terms of teams such as Discharge Without Delay that are looking at trying to support people to go home and have the right services there right now. We're looking at aspects such as hospital at home as well, and you heard about the pilot or the service that's in Elgala Butte. We're about to pilot a similar service in Inverness. So we're very much trying to ensure that people have the right service wherever they are, whether that's in the hospital, whether that's on discharge, and what that looks like at home. But more than happy to pick up with you afterwards if that's something that we can look at for the specific situation.
Is that because I'm the next of kin, so to speak? They always ask. I have been on many people next of kin, so that she called me because her strap was too tight and there was no support whatsoever. I had to try to make it because I'm not professional on that. Took me an hour to sort it out, but I thought, the hospital should have someone to look into. She has been discharged and nobody visit.
No, I'm sorry to hear that, and we certainly will look into that if you're happy for us to do that.
Thank you.
Thank you. Pick that up afterwards. Great, thank you. Any more from the room? I have got like a stack of prepped ones that have been sent in as well. So I might take some of these as well, because these are questions from people who couldn't make it here in person, but they've submitted some really good questions, and I think it would be a nice thing for us to do as a group to go through some of them. So Catherine, the first one I think is going to be for you. So this is about mobile x-rays. So the question that came in is there an opportunity for mobile x-rays in the Highlands? As a radiographer, I attended a conference a few years back about a hybrid Fuji diagnostics vehicle, which brought x-rays, ultrasound and blood tests to the community, obviously then freeing up the hospitals and unnecessary A&E attendance. Would this be something that could be implemented in the future, as it would benefit our widely dispersed populations in the Highlands? So, Catherine, if I can get you to take that one, I'll get you to come up.
Thank you. Catherine Sutton, Chief Officer for Acute Services. So radiology and laboratories actually are undergoing strategic review of services currently as part of our current Together We Care strategic approach. This will see diagnostics integrating with the realistic medicine strategy and also considering new and innovative ways of providing services that support delivering services closer to home. A range of innovative approaches to delivering healthcare to patients across the Highland geography will be considered that utilise advances in technology and continue to improve the timeliness and quality of patient pathways whilst delivering across the Highland and Elgala Butte geography. Our diagnostic pathways will be reviewed as a part of revising patient pathways to ensure integrated service delivery for our patients.
Thank you. Okay, I've just picked another question that I think is quite a timely one, given where we are at the time of year. This one, Arlene, I'm going to ask you to take this one. So this is on vaccinations, so very seasonal. When is NHS Highland going to return vaccinations back to our GPs, as stated by the Cabinet Secretary for Health? Will it be done for this year's vaccinations? So, Arlene, if I could come and ask you to answer that, please.
Thank you. So Highland Health and Social Care Partnership is implementing a collaborative vaccination service delivery model. The model is a hybrid model, which will involve a mix of delivery by our existing in-house vaccination teams and GP practice teams. It was developed through an options appraisal and approved by the Scottish Government General Practice Programme Board in December 24. The aim of this mixed model is to improve overall vaccination uptake and address health inequalities by using the strengths of both teams and services. For childhood vaccinations, with the exception of the school-based immunisation programme, which will continue to be delivered by our in-house Highland vaccination teams, GP practices will have the option to opt in to deliver the preschool vaccination programme. This will be supported by collaborative work with vaccination teams to support increased uptake across our hard-to-reach groups and underserved populations in order to address existing health inequalities. The scope of the delivery of the various adult immunisation programmes between general practice and vaccination teams as part of the collaborative hybrid has yet to be agreed. And I think there was a meeting this afternoon, so very much an ongoing live issue for us. No changes are proposed to the maternal programme delivered within midwifery, the travel health service, which is currently delivered through the community pharmacists, and the delivery to older adults within care homes. A phased approach to implementation is being taken, beginning with the childhood vaccinations model, moving to adult vaccinations once the childhood model has been confirmed. It's intended that we will have implemented the hybrid model for childhood vaccinations by the beginning of April 2026 and for adult vaccinations by the winter programme next year.
Thanks, Sally. By the way, if anybody in the room thinks of another question, just stick your hand up and I'll bring you in. Whilst that was like a seasonal question, I've got one now that feels very locally appropriate. So, Boyd, this is going to be a question for you. It's about Lyme disease. So the person has written quite a long question. I won't read it kind of verbatim, but I'll summarise. So the person who submitted the question talks about the fact that Lyme disease cases are rising sharply across Scotland and no surprise in particular in the Highlands. Yet many patients still face delayed diagnosis and inadequate testing. And they then go on to talk about obviously the impact of that on people. But they've got they've asked us kind of 3 or 4 very specific questions. Yeah. So I'll summarise again. But number 1, will NHS Highland improve awareness and clinical training to help doctors better recognise Lyme disease, even when it doesn't have the classic rash? 2, will NHS Highland acknowledge and address the risks of false negative results, especially for those who've been tested too early? Will we push for improvements in local and national Lyme disease pathways? And will NHS Highland acknowledge that ticks can transmit multiple infections at one time? So definitely a question for you, Boyd.
Thank you. So Boyd, Medical Director again. Yes, it's a very technical question. I think the important thing to say today is that in the Highlands, Lyme disease is well recognised by our doctors and wider than doctors, our clinicians. Ticks are very common in the Highland area, and we have many people whose occupation or lifestyle involves going into tick carrying areas on a daily basis. Therefore, because of that, training on Lyme disease is included for all new GPs who are training in our area. And experienced doctors will also receive regular updates through local educational sessions and on treatment, which is covered in our clinical guidelines, which are available locally and all doctors are familiar with. NHS Highland also hosts Scotland's National Reference Laboratory for testing for tick-borne diseases. So we're a leader in that front. And I can say, having checked with some of our experts, because we have many local experts here already, that we run Scotland's only monthly multidisciplinary meeting for Lyme disease specifically, where GPs and consultants can discuss complex cases. In terms of where we're at just now, and the questions did reference areas that are at the boundaries of research, NHS Highland follows national best practice and will always update care and our guidance as new evidence and new national guidelines become available. We also have a significant number of clinicians who contribute actively to research, sharing their findings on Lyme disease in published journals to form part of the modern medical literature, of which I think we can be proud. Thanks.
Okay, I've got another one. Arlene, sorry, I'm maybe making you do some of the heavy lifting today. It's nothing personal. So question 4 is about adult social care. So a hot topic. Now, just to be clear, the question that's been asked to us was just a general question about do we need a new model for adult social care? That's the question. And what effort is being made to address the disconnection between need and availability in adult social care? This is a little bit technical, but it's important. So I'm going to ask Arlene to come up and talk about that in the Highland context. In Argyll and Bute, that would be the integration joint board that would be in a position to talk about that. But I'm sure some of the messaging will be applicable. But so Arlene, if I can ask you to come and talk about that from a Highland perspective, that'd be great.
Okay, so thank you, Sarah. So adult social care is, as everybody is very aware, experiencing very significant pressures across Scotland. And this is especially felt in Highland because of our geography, our workforce shortages and the financial constraints facing all public services. We know there is a gap between what people need and what is currently available, and we are not satisfied with that position. In the short term, we're focusing on ensuring that the care we do have is targeted safely and fairly, prioritising those with the highest levels of need and maintaining close oversight where care cannot yet be provided in full. This includes strengthened triage work, improved coordination across services and clearer communication with individuals and families. Looking to the future, it is clear that the traditional model of social care based on growing capacity year on year is no longer sustainable. And both Highland Council's Chief Social Work Officer and NHS Highland are recognising the need for a new approach. And that's why we're working closely with partners, including the independent and third sector, to design new models of care that are more local, more flexible, more sustainable, and less reliant on traditional workforce-heavy delivery, and also better aligned to what communities see that they need to live well. This will include the development of a new Highland-wide adult social care model. We're calling it the Highland Care Model, and that brings together prevention, community support, technology and more personalised forms of care, ensuring we use our limited resources to best effect.
Okay, any other questions from the floor? Yes.
Missed appointments in the organisation has gone through the roof. FOI responses proves it's around 40,000 now. With mental health, it's over 6,000. What work is being done and can be done to reduce that ridiculous wastage?
Okay, so missed appointments. So in mental health specifically.
So FOI, so within the organisation, it's over 40,000 now. It's gone up and up and up. And in mental health, it's about 6,000 shown the last year.
Okay. Okay, who can take that one for me? Yeah, Catherine. Helping you get your steps in.
Thank you, Sarah. Yeah, we are doing a lot. Peter, thank you for the question. So we have an outpatient strategy that we're looking at, and a part of that is efficiency and the efficient use of our capacity. So we are introducing something called patient focused booking and rolling that out across the area. So what that is actually speaking to patients to book the appointments with them so that we can be confident that the time that we're allocating to them actually meets their opportunities for attending. What we also do is we will make contact with people if we find that they are missing many of their appointments, and if they haven't managed to turn up, sometimes there are safeguarding issues that we need to consider. So we make contact directly with the family in relation to that. We're also looking at innovative opportunities into the future. So how can we give people something called Choose and Book, which you might have heard about through the English system, where patients can go online and select their appointments themselves using digital technology. We don't have the infrastructure for that currently, but we're working on that as we develop our digital transformation. And all the time we are seeking feedback from patients that do attend or don't attend, to try and understand how we can work with them better to utilise the limited capacity that we've got.
Well, can I just refer to that?
Yeah.
You've got a PR team who next to never put anything out on social media about missed appointments, and it's about £160 per appointment list. That's why your PR team should be helping you.
So something that common.
Because people read social media, and if you prick people's ears up about how much it's costing and people aren't aware of it, it gives people a proverbial boot to actually turn up to an appointment.
That's a really, really good point. Thank you. Well made, Peter.
Yeah, absolutely. Okay. Any other questions? Slightly apprehensive, but I haven't looked out the window for a number of hours, so I don't know. I don't no idea what's going on outside. Okay. Oh yes.
In regards to adult ADHD, it's a topic in the media that we're covering quite a lot recently. We've been made aware recently that NHS Highland's guidelines pathway into getting an ADHD diagnosis has changed, and that has frozen out people that have been waiting for years to see somebody. What assurances can you give those people?
Okay, thank you. Come on, Arlene.
Yes, thank you. So you're absolutely correct that what we've had to do as a result of a huge influx of ADHD referrals into the mental health service and no associated additional resource, what we've had to do is look at the pathway and review that pathway. That pathway has then used what are the NATE guidelines, so the National Autism Implementation Team guidelines, who created them. And we worked with, Highland worked with those guys as part of the pilot for these. We looked at the 4 different levels that are there, and what we've done is we've re-screened every single referral that has come in to the service, and as you say, we've looked and identified where do people sit within those 4 criteria. We are offering individuals who meet the level 4 criteria, which is for those individuals with the most critical or complex needs, an appointment to move forward with their assessment. For those individuals that reach level 1 or 2, we will unfortunately are not able to provide them with a service. For those individuals that reach level 3, we have identified those individuals and we have said to them that what we're doing is we're currently now reviewing the pathway for level 3 people, and what within our existing resources can we do and can we shift around in order that we can provide those people as a service. That part of the work is still underway, and we are hopeful that within the next 3 months we will have an outcome for those individuals that are currently on level 3. But we have anybody who has had a letter that has said that are a level 1, 2 or 3 and therefore are no longer going to be offered a service in the immediate future. There is an option for you to come back to us, and we will triage your assessment with any additional information that people have given us, and that has shifted people around as a result of that additional information that's been provided.
And in terms of those who are now looking at having to go private, do you know, are GPs willing to agree to a shared care agreement with them?
I think that's might be something to bring Boyd in on, because I think it's quite a complex picture across Highland and it's still evolving, so I don't think it's settled.
Yeah, so that's a tricky one in that I think a lot of what Arlene says is what really matters, and there are lots of different, not just ADHD, but there are many different conditions where people will seek private help. They'll pay for that, but the problem is it quite often be outside of the usual diagnostic or treatment criteria the NHS will use. So GPs will tend to be wary of stepping outside of their normal GP practice to do something that private expert has recommended, but which is not within the NHS recommendations, because they don't feel that they would have the legal standing or professional standing that could create a legal or a regulatory problem for them by doing something that isn't common practice. And this is often a difficult boundary, especially when we have conditions such as ADHD, but there are lots of other examples that also fall into this space. Therefore, I think the main advice is that where individuals choose to take a private route, they should research it very carefully, and they might even converse with someone that is familiar with the NHS system before venturing into something that doesn't carry quite the same guarantees or certainty. While the NHS has its limitations, it is founded on evidence and certainty, and moving forward at its pace. Private sector will be different, and it can be helpful to let people know about that difference before they spend their time, money, and put their faith in something that may not be fully acceptable to the mainstream NHS.
Okay, I'm not seeing any other hands up. Just because I'm conscious of weather conditions, and I know that some people have travelled quite a way to be here, I'm going to, I think, bring this particular session to a close. As I said, any and all questions will be gathered up, we'll publish it, all the answers will be online. So even if you've been in this session but you want to go back and look at answers later on, we'll get all of that up for you. I know we've got some colleagues from the media that are keen to do some bits and pieces after that as well. So if I bring this session to a close, it means people can hopefully get home in the daylight, or at least some of the way home in the daylight, and that we're not adding any pressure to our services by there being any unfortunate events in the snow. So I'll wrap up now. Thank you everybody for coming. Thank you for your questions. Thank you for travelling. I really appreciate your time. It's been a really rich day. I've got a lot from the sessions that we've had. We had sessions earlier on with Partnership Forum, Clinical Forum and patients. So there's a lot that I can take away, and indeed others can take away as well. So thank you very much, everybody. Safe travels, please. And see you next year, if not before. Thanks.